Be very much welcome to our webinar for today. The title, as you know, is the very important role that pharmacists have or should have in the management of irritable bowel syndrome, IBS. It is a pleasure to have you on the other side of the screen. My name is Jaime Acosta, Jaime, if you wish. I'm a practicing community pharmacist from Madrid in Spain, and I currently have the honor and privilege to be serving as professional secretary of the community pharmacy section at the International Pharmaceutical Federation, and I will be your moderator for today. First of all, a few housekeeping rules. This webinar is being recorded and can be seen later for those who are not joining us live. And it's also live streamed via YouTube. The recording of this webinar will be available on our website, events.fip.org. I encourage you to look at that website because there's a lot of really high-level educational content available to any pharmacist in the world. You may ask questions using the question box provided. You are highly encouraged to interact with our excellent speakers of today. You're very more than welcome to provide feedback about this webinar and FIP activities at webinars@fip.org. And you can consider becoming a member of the FIP at that website and have access to all the advantages and privileges that FIP members have. Of course, we want to thank our sponsor, Sanofi, who sponsored this online event through unrestricted funds and made it available to you. So this is our plan for today. Our first panelist, Dr. Brian E. Lacy, second panelist, Patricia Suarez, and our third, last but not least, of course, Dr. Samar Younes, and I will have the privilege of introducing them to you in a few minutes. So this is our program. First, the introduction by me. Then we will have Dr. Brian Lacy presenting about the roles of healthcare professionals in the management of chronic gastrointestinal diseases with a focus on primary care. I'm really looking forward to all the presentations. Then we will have Patricia Suarez talking about interprofessional management of IBS in the community. And then we will have Dr. Samar Younes talking about practical tips for pharmacists and disease management of IBS. Then we will have hopefully around 20-15 minutes for our panelists to answer your questions, and then just a few closing remarks at 2:30 Amsterdam time. The learning objectives for today is about discussing the role of community pharmacists around irritable bowel syndrome, understand pharmacists' contributions in interprofessional collaboration in IBS, and identify very important red flag symptoms for referral of IBS patients and management tips. So as you can see, it's a very practical webinar today. So first, it's a pleasure to introduce you to Dr. Brian E. Lacy, who is a board-certified gastroenterologist who focuses his research and clinical interests on disorders of gastrointestinal motility. Dr. Lacy's areas of expertise include gastroesophageal reflux disease, dysphagia, achalasia, dyspepsia, gastroparesis, irritable bowel syndrome, constipation, intestinal pseudo-obstruction, and visceral pain. Dr. Lacy is the author of over 165 peer-reviewed articles on gastrointestinal motility disorders and functional bowel disorders, and has written or edited 6 books on gastrointestinal motility disorders and functional bowel disorders, and has written multiple textbooks, chapters. Dr. Lacy is the current co-editor-in-chief of the American Journal of Gastroenterology. He is the former editor-in-chief of Clinical and Translational Gastroenterology. Dr. Lacy was the co-chairman for the Rome 4th Committee on Functional Bowel Disorders. Dr. Lacy, thank you for being with us today. The floor is yours now. We are all ears and eyes for your presentation. Thank you very much.
Well, it's good morning here in Florida. It's 92 degrees already at 7 a.m. and about 98% humidity. So in Amsterdam or wherever else you are, I'm sure it's cooler and drier. Jaime, thank you so much for a great introduction. I am delighted to be here, and thank you so much for asking me to speak on this important topic. And as you've already learned, I'm not a pharmacist, I'm a gastroenterologist. My emphasis for clinical care and research is that of irritable bowel syndrome. But my talk today is going to be a little bit different because I'm going to assume all of you know so much about IBS, and as pharmacists, I know you provide so much great care for your patients. What I'm really going to speak today about is chronic GI diseases using IBS as really the substrate and talk about communication. That's really my task today. By the way, I do not have any conflicts for this lecture. So let's begin. And managing chronic GI disorders, whether it's IBS or diabetes or thyroid disease or heart disease, managing chronic disease can be challenging for everybody in the audience, including me. Time is limited. We're all so busy. We're asked to do so much more. Think about the paperwork and the regulations. Think about patient burden. You're seeing so many more patients and asked to consult so many more patients than you used to. And patients are more complicated. 30 and 40 years ago, they had very simple problems. Now they have multiple problems that are of higher intensity. And of course, patients come to see you as a pharmacist, and they're much more aware than in the past. They're better educated, which is great. But of course, they've been working with Dr. Google, and they come in with a lot of misinformation. And of course, we have many more treatment options than in the past. Think about Crohn's disease, where everybody 30 years ago was treated with steroids only, but now think about the multiple options. And remember, chronic means chronic for IBS. We can't cure it. Our job is to help improve patient symptoms. So how can we address patients with IBS, and how can we help deal with these symptoms better, and how can we communicate better, whether for IBS or other chronic GI disorders such as reflux disease or dyspepsia? So the first concept is to really listen and listen actively. Let the patient tell his or her story. If you listen carefully, he or she is giving you the diagnosis. And this is not just part of the diagnostic process as a pharmacist, but it's also part of the healing process for the patient. And by listening carefully, you'll help identify the patient's agenda and you'll identify their goals. And at least in the United States, we have good data. The average provider interrupts after 18 seconds. Don't do that. Be a better listener than providers in the United States. Listen to the story, you'll get the answer, and you'll help the patient. And as you're listening, remember, nonverbal cues are really important. Ideally, you're in a private area, it's comfortable, you're making eye contact with the patient. You should be relaxed with this open body posture, not closed, not arms crossed. As patients mention certain things, you may want to nod appropriately, let them know you're listening and interacting. You should be close to the patient, but not too close. You want that appropriate physical distancing, and hopefully a very nice, gentle, moderate tone with correct timing and pacing of what you're saying. Don't interrupt. And always begin with open-ended questions, right? So Mrs. Jones, what brings you in today? Then as they provide their history to you, close things down to test a hypothesis or plan. Don't be afraid to use the patient's own words. When they say, I have terrible urgency, say, Mrs. Jones, I understand urgency is a problem for you. Is that correct? And make sure that along the way, you're using brief summary statements to kind of confirm what they've told you. Keep in mind, follow the thread of the story. Don't let them wander. Appropriate reassurance and encouragement is helpful. And sometimes periods of silence can be absolutely transformative. And this feels very awkward, but it's okay to ask a question. And then there can be a 15 or 20-second pause there. That's okay. The tendency is to jump in very quickly. just wait a second and see what the patient says. Of course, as you're interviewing the patient and they're bringing their problems to you, you should be a bit of a skeptic and asking, is the diagnosis correct? And certainly for IBS, making the correct diagnosis can be difficult because symptoms fluctuate over time. Patients may have good weeks, they may have horrible weeks, and symptoms don't always seem to respond to the appropriate therapy. As an example, maybe fiber is great for one patient, but another patient with similar symptoms, fiber does nothing or makes things worse. Similarly, low paramide may help a lot of patients, but may not help everybody with IBS and diarrhea. In addition, other disorders, which we'll cover in a second, can mimic IBS. And at least in the clinic, we don't have a great biomarker yet. We don't have a blood test that can confidently and consistently diagnose IBS. In addition, guidelines are not always employed. So how do we make the diagnosis of IBS in clinic, and how can you make the diagnosis? By taking that great clinical history, asking about their medical and surgical and dietary history, asking about allergies and adverse drug reactions, and looking for those alarm and warning signs, which I know will be covered later. In clinic, at least for providers, we recommend an exam that's guided to the abdomen, looking for other things that could mimic IBS. So the presence of ascites would argue against IBS, the presence of a mass or lymphadenopathy example. We use the Rome 4 criteria, which I'll cover in a second. And for the vast majority of patients, very simple tests, a blood count, a CRP, a fecal calprotectin may be all that's necessary. And for young patients, a colonoscopy is rarely necessary. So we use the Rome 4 criteria. This has been well validated, and IBS by definition is defined as recurrent abdominal pain. It does not have to be present every day, just one day a week on average in the last 3 months. That speaks to chronicity. And the abdominal pain should be associated with at least two of the following: related to having a bowel movement, related to defecation, associated with a change in stool frequency, or associated with a change in stool form. So basically, the presence of abdominal pain with altered bowel habits, that's IBS. Now, what are some of those conditions that might mimic IBS? So think about patients with lactose intolerance. And certainly in Europe, at least 35% of patients are lactose intolerant, and that can cause gas, bloating, urgency, and diarrhea. In some populations, in Asia or Africa, it may be as high as 90%. Fructose intolerance, as pharmacists, you recognize, we do not have the enzyme to break down fructose. Fructase doesn't exist. And so small amounts of fructose can cause problems. Bacterial overgrowth, celiac disease, 1 in 100 in Europe. Non-celiac gluten sensitivity, 30% of patients with IBS are sensitive to gluten, but they do not have celiac disease. And of course, IBD and microscopic colitis might mimic IBS. So as you're interviewing the patient, you're trying to understand, what is the patient's agenda? Why is she or he here today? What brought you here today? What's bothersome to you? And you're trying to understand the patient's perspective and understand their illness condition. What do you think you have? And so I will always ask patients, what do you think is going on? What do you think you have? And it's also really important to understand the illness from a social and cultural perspective. What worries or concerns do you have? And what are your thoughts, and how can I help? Are key questions. As you interview these patients, you need to understand, might there be barriers to communication? As an example, maybe their language is not the same as yours, and is language an issue? Do they really understand what you're asking them? Are word choices appropriate? So be careful about word choices, because based on their education or experience, they may not understand what you're asking them. And you may want to use diagrams or pictograms. So for an example, for many of our IBS patients here, we use the Bristol stool form scale, using those pictograms to help patients identify their bowel habits. And patients like them this way. We're using the same language. Maybe they're not embarrassed then that they're not using correct language. And are there cultural issues you might need to be aware of? For example, bloating is really not a word that's used in Central or South America, and we see many patients here from Central or South America, and bloating may actually be misinterpreted as pain, and you'd be having a completely different conversation. educating the patient is critical. Remember, knowledge really is power. And so you're in a position with all of your experience to help take the time to understand what the patient knows about the disorder. You need to elicit the patient's understanding of this disorder, and you need to address misunderstandings. And as you're doing this, you'll want to understand the educational level of the patient. Did they graduate high school? Did they go to college? Do they have an advanced degree? Because that will help you tailor your discussion to that patient. And oftentimes, one trick I use is I'll ask the patient, if a friend of yours you haven't seen in many years comes to visit you this weekend, how would you explain your condition to them? It helps me understand their level of knowledge, and then I can fill in the gaps for them. And as I've already mentioned, it's critical to address the patient's concerns and understand. As an example, IBS patients are frequently concerned about a misdiagnosis. And we did a study many years ago with over 800 IBS patients that 30% mistakenly believe their symptoms represent a missed malignancy, such as a missed colon cancer. And with a good exam, a good history, and the absence of warning signs, that almost never happens. And 30% mistakenly believe that IBS will progress to inflammatory bowel disease. That's not true at all either. So help your patients identify goals for their treatment plan, but make sure they're realistic goals. So can we identify the cause? That's not always possible. Maybe it developed after an infection or food poisoning, but we can't always identify that cause. Make sure you don't fall a trap where you keep recommending extensive testing and a battery of tests that are repeated. That's rarely likely to uncover something. And make sure you don't keep repeating treatments or recommendations for dietary modification example that's already been done. That just sets you down a path you don't want it to go down. So identify the goals first, place the goals in a proper context. And as an example, a phrase that I might use with some patients is, I can understand how you would like all of your symptoms to go away immediately, but you've had these symptoms for 5 years, and it's unlikely that we're going to solve this condition overnight. So this helps set expectations for the patient. And make sure you empathize with the patient. And remember that empathy is very different than sympathy. Sympathy means, oh, this is terrible, woe is you. Empathizing means that you understand the patient's pain and distress. Sometimes it feels a little unnatural, but you can teach yourself how to do this. And it's maintaining objectivity. So key phrases you may want to incorporate in your discussion are, I can see how this has been so difficult for you to have these symptoms, or I can see how this has affected you. That's empathy, not sympathy. And of course, as you're having these discussions, whether it's reflux disease, dyspepsia, IBS, chronic constipation, diabetes, you want to validate patients' thoughts and feelings. Remember, these interviews you have are very personal and intimate, and patients may bring up information that they may feel embarrassed about. And sometimes they bring up information that may challenge your worldviews about healthcare or even about that patient. So you need to maintain your sense of neutrality. And not understanding the need to validate the patient's thoughts and feelings can lead to rapid decisions that could really harm the patient and their view of your care with them. So you want to provide this very open environment. You want to be accepting of their feelings. And as an example, one phrase you may again want to incorporate, I can see how upset you get when your family says that all of your IBS symptoms are in your head, because I've heard that phrase so many times before. All right, so what are your goals to make a great patient visit? One is, we've talked about education, but also reassurance. So identify the patient's worries and concerns, acknowledge their IBS symptoms, validate the worries and concerns. Do not reassure falsely or too prematurely. You want to reassure the patient, just be cautious as you're getting to know the patient. But do remind patients that IBS never turns to cancer, IBS never turns to inflammatory bowel disease, and we have lots of good data that IBS does not shorten lifespan. Also, as a pharmacist, you may need to negotiate with the patient in terms of therapy. That patient-centered care is based on the patient and the provider agreeing on diagnostic and treatment options. We know that treatment adherence is much better when choices are offered to the patient and the patient, with a good discussion about risks and costs and benefits, chooses a specific therapy. They should really help make that final decision. So in my practice, oftentimes it's revolving around diagnostics. And as an example, a patient I saw recently wanted another CAT scan, but in the last 5 years, other providers had ordered a separate of 5 separate CT scans, all of which were normal. Of course, they're normal in patients with IBS. And so I asked the patient, what do you think we'll find with another CT scan? You may change that language to say, Mrs. Jones, in the last several years, you've had 4 different drugs for diarrhea and none have helped. Why should we repeat that? Should we look for another option for your IBS symptoms? Maybe using a neuromodulator as an example. And of course, you want to help the patient take responsibility. Many patients with chronic illness, chronic heart disease, chronic pulmonary disorders become helpless or dependent on you, and you can't do that. You can't take responsibility for all of your patients' symptoms and illnesses. It will lead to burnout. So it's critical that they take responsibility. And of course, outcomes are always better when the patient is really involved. So you don't ask your IBS patient, how is your pain today? What you ask is, what have you been doing recently to help your IBS-related abdominal pain? What have you been doing recently to help your reflux symptoms? Give them some control, make them take responsibility. So if we start thinking about how to summarize the management of IBS care using really a patient-centered approach and asking, what do your patients really want from you? And by the way, though, we could substitute the word GERD here. We could substitute chronic constipation. We could substitute bloating and the GI disorders. They want you to listen. They want to be educated. They want some reassurance from you. They want a positive diagnosis. Yes, based on your symptoms of abdominal pain that have been present for 6 months and they've been active in the last 3 months, based on your symptoms of altered bowel habits with coexisting bloating, you have IBS. This is your diagnosis. And then, of course, they want to feel better and they want treatment options explained. Finally, as you start wrapping things up as a pharmacist, you want to make sure you've communicated information to all the members of the team approach, because a team approach is always better. And whether that's the internist, whether it's the local gastroenterologist, whether it's the dietitian, all the team members should be involved. And you want to make sure that this communication is clear and cohesive and congruent. As an example, make sure you use clear language. Do not say, well, Mrs. Jones, maybe you have IBS and it's possible some of your symptoms represent IBS. What you want to say is, you have IBS, you're suffering from IBS. I've made the diagnosis of IBS. Be very confident. You have a lot of experience in education. Feel free to use that clear language. So in summary, this is Dr. William Osler, as you know, really the father of American medicine. When you manage chronic GI disorders, including IBS, you want to listen, you want to understand the patient's agenda, you want to empathize, not sympathize, very different. You want to validate the patient's thoughts and feelings, you want to set realistic goals. You want to educate the patient and reassure and learn to negotiate the patient. Make sure you help the patient take responsibility, and you want to be present in the moment to help that patient. Thank you so much for attending here today. Absolutely honored to be able to speak on communication and IBS symptoms, and delighted to answer questions later. Thank you so much.
Thank you, Brian, for an excellent presentation. About communication. Pharmacists, we are very good with communication, not only because we are very close to patients, not only geographically, accessibility, opening times, but we really know how to build trust in relations. And so it's a very important thing that really helps patients, is being able to communicate better with them. That really improves outcomes. And I just want to mention a phrase I heard from Lacy Sutherland, who's an FIP vice president, that this has been resonating in my mind after I listened to it. It's something like patients do not care how much you know until they know that you really want to take care of them. And that's something that we really need to have in mind. Thank you, Brian.
No, I like that. Thank you.
So our next speaker is Patricia Lorenzo Suarez, who's the head of innovation and partnerships for Nova Health Campus at Nova University, with 6 years of experience working alongside stakeholders within the health sector. Patricia specializes in developing impactful programs for citizens, from patients to health professionals. She is committed to writing the stories that we all want to live, as her work expands from business development to community building, including communication and storytelling. Patricia is a dreamer with a plan, working in programs that aim to improve access and quality of care for citizens. Inspired by the words of Team Amanda and Ngozi Adichie, culture does not make people, people make culture. Patricia has stopped talking about feminism over coffee and instead spreads the word to a wider audience behind the mic at the podcast A Culpa et Delas. Thank you, Patricia, for being with us today. The floor is yours. Thank you so much.
Thank you, Jaime, for a wonderful introduction. And I cannot be happier to be amongst colleagues. So first of all, thanking FIP for the wonderful invite to join you in talking about one subject that is so dear to me, that is IBS. And so now really just adding on, I'm a pharmacist, and it's so wonderful to be here talking about the opportunities that we as pharmacists have to carry in bringing everyone to the table. So, as we all know, knowledge takes time, and for sure this could not be truer for IBS. With a quick search, you can really see that in the last 30 years, we have slowly evolved in getting to know this subject and this disease. And in the last 10 is when it really caught on fire with getting attention and research on IBS. And this really means that the stars have aligned for us to have a better grasp on how to better treat these patients and how to better engage with these patients. But we also know that knowledge doesn't seek into everyday practice overnight. So things do take time. And as you can see in the next slides, what can we really expect when talking about IBS? As Brian already had the pleasure of sharing with you, IBS is a chronic relapsing disorder of the gut-brain interaction, and we know that it affects between 5 to 10% of otherwise healthy individuals. But at the same time, perceptions from patients are not so happy. Patients perceive doctors to show lack of empathy during IBS consultations, and also do feel that the information that they have or that they are given about symptom management is not sufficient. At the same time, IBS takes a long time to be diagnosed, and sometimes, as it has been talked about, IBS mimics other diseases, or most of times, I believe, the symptoms are overlooked as something that you just live with. So IBS takes a long time to be diagnosed, and up to 4 years to get to that conclusion, with some reports showing that it can take up to 7 years to have a final diagnosis. It's more than evident that IBS has a substantial impact on quality of life and social functioning for people living with IBS. And if we go back to evidence in the next slide, we do see in this table that was part of a systematic review published on Lancet 2 years ago, that it's not just about having evidence, it's the quality of data that we have that better equips us to make decisions and to engage with patients. And what we see clearly for me is what I would call a sea of what ifs. What if is something that we need to look upon. And if we see in the next slide, some researchers do claim that the prevalence in developed countries for IBS could be as high as 20% of the population, and that it is a significant challenge faced by physicians, and I'll address the point of talking about physicians when I'm talking to pharmacists, in physicians to introduce the appropriate treatment, and that is often ineffective. So what if we had diagnosed these patients sooner? What if the expectations that we have or that the patients have can't only be met by doctors? What if there's really a need for a personalized approach to each patient needs, and it's not something that we can bundle up into some kind of one-size-fits-all guideline? So if we can look in the next slide, then we go back to the table that I just showed you. The table really focus on first-line treatments in two aspects. On one hand, it talks about diet, lifestyle, and probiotics. And so you can see exercise, a low food map diet, and you can see that fiber is also in motion. But in the other hand, we see first-line therapies to be most OTCs in several countries. So the first-line drugs that could be used in IBS are OTCs for most countries, which may lead us to also think that it's unfair to all brilliant doctors out there and all gastroenterologists to be taking the blame for all of us that are not taking the lead and taking a seat at the table with the patient. As we can see, it makes perfect sense to think, when we think of IBS as a gut-brain disorder, to think about psychological support and psychological aspect of IBS to be something to be considered. If we understand, and it's well understood, that diets and microbiota have a play in IBS, why are we including nutritionists in this kind of treatment and management? And at the same time, for sure, there's a role for pharmacists to be better at managing and helping to manage everyday life for patients with IBS. If we look to the next slide, and I'm sorry, Brian, but we haven't met until today, but we took the same kind of knowledge takes time for me, but knowledge is power. And for me, more than power, knowledge when shared, and Inez, you're going to have to help me, thank you. Knowledge shared is a power that is multiplied. And this for me is really the key that I wanted to present to you today, is that if we think about silos of information that each health professional is carrying with him through his professional life, and for the patient itself, really we cannot do much by ourselves. So if we look into the patient journey on the next slide, we can really see how leaving it all to the GP or to the specialist, it's really the beginning of a vicious cycle in the patient journey. You get a diagnosis, sometimes it takes a long time to get a diagnosis, and then you go back and forward with your doctor or physician, wondering if they are going to be the ones, the key to all your needs. And what you end up as a patient is with symptoms that go and then go and come, so that you have acute times, and then you go back to everyday life. You have a couple of months that are better, or a couple of weeks, and then you cannot take it any longer. So the house is on fire, and you're trying to make something of it, when really we should go and look at the patient journey, as we can see on the next slide, and thinking that maybe what we are seeing in our patients is that they are really not getting the signals for a way out of this vicious cycle. As in complementing what Brian was sharing with us, I could not agree more that the expectations that patients have in their everyday management of IBS, it's also something that we as health professionals have to take into consideration in how can we prevent the disappointment that evidently IBS has no cure, but it can be managed over time. And how can we really build up on the confidence that healthcare professionals should have from their patients? How can we also engage with patients so that they don't feel that they are trapped by their disease? And how can we really get the most of the available treatments for IBS? So if we did that, if we did engage the patient in a different manner, how will that look for the patient journey? How will the patient journey change? In the next slide, really, we can see that maybe if we start engaging in a different manner, in this is something that has already had some evidence behind it, we can really start to see a shift in patient outcomes, because really we don't get the house on fire and burning when it's out of control to get to a specialist. We start taking care of patients and engaging with patients in the primary care level every day at the pharmacy, with a nutritionist, with a psychologist. And then when things get out of hand for any kind of situations, a specialist such as a gastroenterologist can come into play, knowing also that there's a team working besides him. So it should come out for getting out of the vicious cycle to have primary care interventions. And the question might be, how can we do that? Or how do we organize in that sense? So in the next slide is really to think about how knowledge can be shared so that our power as health professionals can be multiplied. And we can see this evolution of IBS care is that if we focus on a traditional model where the physician is the sole responsible, we are failing as health professionals, as pharmacists. We are also not only failing the patient, but also failing our colleagues, doctors, gastroenterologists, when we don't take a step forward to make it also about us in the care team. So if we leave it only to the GP, we are not taking full responsibility. Also, not only the patient is getting worse symptoms and getting worse over time, but really, if we just take a little step to the side and get on the table, at the table, but we don't engage with each other, we are still in the what ifs situation. So a multidisciplinary care, it's better than just leaving it all to a doctor. But at the same time, if nurses, pharmacists, nutritionists, psychologists are working independently and they don't talk with each other, to the patient, with the patient, how can we really expect to get the best of each health professional? Because every one of these health professionals can have a better grasp and a better contribution in different times of the patient journey. So it's time that we really start moving on for integrated care, that we start thinking about team-based approaches, that we are collaborative, and that we really focus on interprofessional care for IBS. We can see in the next slide, and the future really is now. Almost or really a year ago, I found this very nice article that had this tagline that I loved, because integrated care is something that we should be doing right away, tomorrow. At our local pharmacy at our everyday life, we should be engaging in thinking of ways in which we can collaborate for integrated care for irritable bowel syndrome. So in the next slide, how do we get there? And being a pharmacist now working at the university level really gets me to think about how we can engage on different levels. Because when you think about universities, and we all know that pharmacists are academics also that have a good play in the university world, and that can be demanding on that world too. We need to engage in universities to prepare students for new care models, for team-based learning when they are really challenged to, from day one, interact with other students from other health professional courses. So we need to empower these future healthcare professionals to seek new solutions for vicious cycles. It's not only for IBS, it could be a solution for many diseases. But as we're talking for IBS, this vicious cycle could be the solution that we get from new healthcare professionals when they start to engage with each other early on in their learning journey. But at the same time, it's because it's not only about the new generation, talking about those who are already in the market and who are working. We need to engage with those healthcare professionals. We need to, as we are doing today, get health professionals and pharmacists, nutritionists, GPs, doctors to engage in lifelong learning, where they can refresh their learnings. Their learning curve that we had that was really stable, not needing to keep up and update or only on diseases but not on methods, it's obsolete. We need to keep up with new methods of and new care models. And at the same time, let's use universities as a playground for showcasing best practices. Let's use universities as places where it's safe to trial and error new care models. So that when we talk as health professionals and to healthcare professionals, we can really start seeing that we need to recognize which step of the patient journey we can serve best and how. So if we're talking about diagnosis, how can I make a difference as a community pharmacist? How can I make a difference in management? And which kind of symptoms can I better? And which kind of symptoms, in the other hand, can I refer to other healthcare professionals? Be aware as healthcare professionals that we need to share. Sharing is caring, because for patients, it's nothing, it's solely on them, and it's a very overwhelming sensation to be the sole bearer of all the information of all that has happened. And at the same time, if we do alleviate that burden for patients by doing referral, it's not a typo. It's really some of the best takeaway I have for you is that we need to, as pharmacists and for all health professionals, we need to start engaging with each other by starting to recognize when and how to do a referral. And then, before being health professionals, all of us are citizens in their own countries and communities. And it's a main issue. It's so important in my point of view, in my career. I've seen it to normalize talking about IBS and to normalize talking about GI diseases. It's a hard and taboo subject in many countries, in many communities. And how can I talk about my symptoms if I don't feel comfortable sharing about those kinds of symptoms that are taboo, that are seen as something that is dirty and not good to share with anybody? And this normalizing is how we also get people living with IBS and people who might be living with IBS and do not have a diagnosis to really be their own best advocates. So when engaging with people living with IBS and with patients, it's important to encourage and empower them to be the ones speaking up early, to speak up completely about their concerns, what would they like to have covered in their consultations, what are their fears, because some of the misconceptions that we heard Brian talk about are really about the lack of communication about concerns and what the symptoms mean to the patient. And also that we can engage often, for sure, patients should be the ones also speaking up and speaking up often, to make sure that we as societies, as health professionals, as universities, as citizens are ready to listen. In the next slide, and wrapping up, really a special note to all of my colleagues, pharmacists: act locally, but think globally. Things change when we change in the communities, and really I believe that pharmacists have the best seat in the house to start implementing change, because we can be the ones starting conversations that might have not happened in the past, but might be really on its way to start aligning and be ready to engage. So if community health professionals such as ourselves as pharmacists are ready for collaboration, amazing things can be done. So if we think locally, starting in our daily practice, if we pilot ROM criteria for diagnosis, implementing a patient journey follow-up, if we start looking into what referrals can we do at the local level, we can really start seeing new opportunities for our patients and for patient engagement. We can really start to see how can we put the patient in the middle, and how can we engage at the local level for better opportunities for our patients too. And at the same time, listen, because the clues are out there. And it's my belief that there are many IBS patients that we see every day, that talk to us every day and have no clue until this moment that they have IBS, because we sometimes are not actively listening and caring for the information that is being given to us to really make the connection to the dots. That could be an IBS diagnosis in the making. So my challenge to you is to start today, if not to start tomorrow at the local level, and to, I hope so, in a couple of months, have the chance to hear about your adventures in engaging with IBS patients. Thank you so much. I'm so happy to get your attention on this subject, and so ready for your questions.
Thank you, Patricia, for another excellent presentation. Very inspiring. I was amazed with the number of 20% potential prevalence of IBS. So there's, as you said, there's a super big value in the structure defined screening service for IBS in community pharmacies to improve the diagnosis, make it earlier, and put the patients on the right path. Apart from all the other things that you mentioned, maybe a medicines use review service in collaboration with the GP, the specialist, the nutritionist. I mean, there's a lot of things to do, and I wasn't really aware of this potential. Thank you so much, Patricia. So
thank you, Jaime.
We move on now to Dr. Samar Younes. Dr. Younes is a registered pharmacist who earned her Bachelor of Pharmacy degree in 2009 and her PharmD degree in 2011, both from the Lebanese International University. She also holds a research master's degree in pharmaceutical biotechnology from the Lebanese University in 2018. Dr. Younes is a clinical associate professor at LIU, which she has joined since the year of 2011 and still. In 2014, she was appointed as Assistant Dean of the School of Pharmacy at LIU, the campus, and currently she is the chairperson of the Biomedical Sciences Department. She has earned an experience as a course instructor of various courses, and among them, for example, pharmacology, pharmacotherapeutics, and pharmacy practice experience. She has participated in many national and international conferences where she presented scientific lectures and posters and conducted many studies that were published in peer-reviewed journals. She is a member of the Order of Pharmacists in Lebanon, OPL, the International Pharmaceutical Federation, and the American Association of Colleges of Pharmacy. Thank you, Dr. Younes. The floor is yours. Thank you.
Thank you so much, Jaime, for your introduction and this warm welcome. Good morning, good afternoon, good evening, dear colleagues watching us from all over the world. I want to extend my heartfelt thanks to FIP organizers for inviting me to talk today. I would also thank our speakers, Dr. Brian and Patricia, for introducing the topic and for their great presentations. In my turn, I will be covering the main treatment options for IBS, as well as some tips on how to support these patients through community pharmacies. I have no disclosures relevant to this presentation. Sorry. Learning objectives. By the end of this session, participants should be able to identify and recommend non-pharmacologic and pharmacological treatment options for patients with IBS, discuss indications, adverse effects, and mechanism of action when considering available treatment options for IBS, and recognize the role of community pharmacists in supporting patients with IBS. So first, what is IBS, or irritable bowel syndrome? As discussed previously, it is a complex gastrointestinal disease. It is one of the most commonly diagnosed GI conditions. It's usually defined by the presence of abdominal pain and is associated with changes in the frequency or consistency of stool. Due to variations in symptoms, IBS diagnosis is not always easy. And because of these uncertainties, IBS is a diagnosis of exclusion. How to classify IBS? We have three main classifications: diarrhea predominant, constipation predominant, and mixed IBS. When we say diarrhea predominant or IBS-D, this is characterized by having loose or watery stool, 25% or more of the bowel movement, with hard or lumpy stool, less than 25% of bowel movement. However, for constipation predominant IBS, we have hard or lumpy stool, 25% or more of the bowel movement, with loose or watery stool, less than 25%. Patients who have more than or equal 25% of bowel movement being hard or lumpy and loose or watery, they are considered to have mixed IBS. Some patients may have IBS which is not classified. Such patients, they meet diagnostic criteria, however, they cannot be accurately categorized into one of the three subtypes. It's very important to note that pain is a common feature of all types of IBS. It's well known that IBS symptoms negatively impact patients' quality of life. The frustrating symptoms of IBS, as well as its chronic nature, lead patients to constantly seek medical care. And as you know, pharmacists have a vital role in patient education and in the drug therapy management of IBS, and they can help ensure safe and efficacious treatment. Therefore, it is essential for pharmacists to have ample knowledge and information on IBS in order to provide appropriate consultation to the patient suffering from such a chronic condition. So, what lifestyle changes may help alleviate IBS symptoms? It's very important for pharmacists to advise patients with IBS to do what? First, to increase their physical activity, exercise. Regular exercise is known to help in easing the symptoms of IBS. Plus, it's very important to counsel patients to keep a symptom diary. This may help to keep a food or lifestyle diary for 2 to 4 weeks in order to monitor symptoms and activities. This means we advise our patients to note everything that they eat, that they drink, times they were stressed, because stress can aggravate or cause symptoms, weight loss if they have experienced an extreme weight loss, if they took any formal exercise. So this may help in identifying triggers such as food, alcohol, emotional stress, and may show if exercise was helping in easing or preventing the symptoms. Plus, managing stress levels. Stress and other emotional factors may trigger symptoms. in some people. So anything that can reduce the patient's level of stress or emotional upset may also help. Involve your patients in the treatment plan. Patient education, as previously discussed by Dr. Brian and Patricia, is very important, is essential for any successful management plan. So in the case of IBS, this includes offering the patient a clear, easily comprehensible explanation of the pathophysiology of the disease from which they are suffering, its causes and symptoms, as well as the role of psychosocial factors in its presentation. Patients presented with detailed discussions about their diagnosis and treatment options have usually reduced symptom intensity. Reassurance, again, reassurance. Provide patients with firm reassurance, emphasizing that their symptoms are known to be real. They are not just in their heads. Emphasize that the patient is not alone in his suffering. His prognosis is benign. IBS is a chronic disease. However, it does not increase the risk of malignancy. So usually when well-informed patients have better control of their symptoms and better or less severity of their symptoms. Now moving to dietary modification as a non-pharmacological management option for patients with IBS. So it has been demonstrated that patients with mild to moderate symptoms typically are more responsive to dietary modifications. Therefore, pharmacists should encourage patients with both constipation predominant and diarrhea predominant IBS to follow or to incorporate fiber in their diets, because fiber is known to gently stretch the bowel wall and therefore decreasing the tension. So we advise patients to increase fiber intake. However, this fiber intake should be increased gradually, because usually excess fiber can cause bloating. Excess fiber can worsen symptoms. So we usually begin to see effects after 3 to 5 days of starting fiber, but make sure not to go for excess fiber. Plus, we advise patients to exclude food that increase flatulence, food that cause production of gas, such as beans, onions, celery, carrots, raisins, bananas, apricots, and so on, in addition to alcohol and caffeine, which are also known to cause gas production. What dietary modifications we have also? So dietary triggers avoidance. How to determine dietary triggers? Patients should try an exclusion diet. This means restricting their diets to basic bland food, gradually then adding a new food and recording their symptoms. So any food which can cause symptoms should be avoided. However, it's very important to counsel your patient that such elimination diets are intended only for short-term use. Why? Because they are nutritionally deficient, and therefore they should be supervised by a dietitian or medical professional with experience in this field. What about lactose avoidance? So usually lactose restricted diet is considered for those patients with lactose intolerance, and gluten avoidance, usually a 2-week trial of a gluten-free diet is considered in patients with IBS-D, those who have persistent symptoms despite a diet which is low in FODMAP and gas-producing food. What do you mean by FODMAP diet or low FODMAP diet? So usually this diet is considered in patients with abdominal bloating or pain despite exclusion of gas-producing foods. What is the theory behind that? This says that fermentable oligo, dye, and monosaccharides and polyols, so this is the meaning of FODMAP, such patients, when they take FODMAPs and they have IBS, these types of food or diet would enter the distal small bowel and colon where they are fermented, leading to symptoms and increasing intestinal permeability and possibly inflammation. What examples of FODMAPs do we have? For example, fructans, such as those found in wheat, in onions, in artichokes, galactans, such as those found in legumes, cabbage, and processed sprout, lactose in milk, custard, ice cream, and yogurt, fructose, in addition to polyols such as sorbitol, xylitol, and mannitol. So low FODMAP diet may help such patients. So now moving to general approach of treatment, what medications we will go for over the options of medications used for treating patients with IBS. But it's very important to note that the symptoms or the treatment is usually based on the predominant and severity of symptoms. So for example, patients with abdominal pain or discomfort, treatment options may include antispasmodics, tricyclic antidepressants, analgesics, serotonin agonists or antagonists. For bloating or distension, we have dietary modifications, antispasmodics, antiflatulents, digestive enzymes, antibiotics, and serotonin agonists, antagonists. For constipation, predominant, we have fibers, osmotic agents, lubiprostone or linaclotide, in addition to serotonin 4 agonists. As for diarrhea, we have loperamide, cholestyramine as a bile acid sequestrant, and serotonin 3 antagonists. But make sure, note that none of these medications effectively treat all the symptoms of IBS. And some of these medications may exacerbate some symptoms of IBS. For example, we previously discussed now, fibers may help in the bowel movement. However, fibers may worsen bloating. Antispasmodics may reduce the abdominal pain, the abdominal discomfort, but they may worsen constipation because they have anticholinergic effects. Starting first with the constipation predominant IBS, so IBS-C, treatment options include laxatives. So first we have bulk-forming laxatives such as psyllium. So we have good evidence on psyllium. However, as you know, such bulk-forming laxatives may also exacerbate bloating and cause gas formation. Calcium polycarboxyl is an alternative bulk-forming laxative, and methylcellulose can also be used. In addition to bulk forming, we have polyethylene glycol-based laxatives. They have shown to improve constipation, but not abdominal pain. They have less side effects compared to other osmotic laxatives. However, also bloating and abdominal discomfort can limit their use. Stimulants are better to be avoided because they worsen abdominal pain, and other laxatives are used only in the smallest dose for the least amount of time in severe cases of constipation. Other option for constipation is linaclotide, which is approved for adults with moderate to severe IBS-C having persistent constipation despite treatment with polyethylene glycol. It has shown to increase GI motility and reduce visceral hypersensitivity. It's given as a dose of 145 to 290 microgram capsule every day on empty stomach at least 30 minutes before the first meal. The duration of treatment is at least 12 weeks, and if there is no improvement in 4 weeks, we advise to change treatment. It has a rapid effect within the first 24 hours. However, its effects are sustained through 16 weeks. Long-term risks are still unknown. Most common side effect associated with linaclotide is diarrhea. We have other GI side effects, but it's very important to closely monitor severe or prolonged diarrhea. That's why any patient who is prone to water or electrolyte balance disturbance should be cautiously given linaclotide. Lubiprostone is a locally acting chloride channel activator that also increases motility in the intestine, facilitating the passage of the stool and possibly alleviating pain. Also, long-term safety is not well established. It is approved for women, so adult women 18 years or more with IBS-C despite using polyethylene glycol. Side effects, most commonly nausea and diarrhea. So if patients experience nausea and diarrhea, we advise them to give or to take lubiprostone with food. If severe diarrhea, they should immediately contact their physician. Other side effects may include dyspnea, bowel obstruction, in addition to other side effects. They are contraindicated in mechanical GI obstruction and never started in patients with severe diarrhea. There is no restrictions for the duration of using lubiprostone, but up to 52 weeks, usually based on safety studies. Prucalopride is a selective high-affinity serotonin 4 receptor agonist that will also target motility. It will improve motility associated with chronic constipation. It's usually well tolerated, associated with mainly nausea, vomiting, headache, irritability, and fatigue as side effects. It is contraindicated in patients with hypersensitivity, severe renal impairment, patients on dialysis, colonic obstruction, and patients with IBD. These were the treatment options for constipation predominant IBS. So what if my patient is having diarrhea predominant IBS? What would be the treatment options? So first we have anti-diarrheal medications. So anti-diarrheal agents, they include loperamide. All of you know loperamide, which is an OTC anti-diarrheal medication. However, loperamide have no effect on the pain. It can only reduce motility, increasing the stool consistency. How to give loperamide? It's given as 2 milligrams, 45 minutes before a meal on regularly scheduled doses as adjunctive treatment in patients with persistent disease following dietary modifications. Another antidiarrheal agent is iloxadoline, which is a mu receptor agonist, delta receptor antagonist. It is indicated for both men and women. It's commonly associated with GI side effects, nausea, vomiting, constipation, abdominal pain, in addition to upper respiratory tract infection, nasopharyngitis, pancreatitis, mainly in patients with biliary disorders or alcohol use. In patients who develop severe constipation upon the treatment with iloxadoline, they are advised for more than 4 days, they are advised to discontinue the medication. Other than antidiarrheal, we have bile acid sequestrants, which can be also used for IBS-D. Bile acid sequestrants, they include cholestyramine, cholecystipol, and cholecyvalam. So such medications, they are indicated for patients with persistent diarrhea despite antidiarrheal medications. However, as you know, bile acid sequestrants, they have limited use because of GI side effects, because bloating, flatulence, abdominal discomfort, and constipation. Alocetrone is another option for diarrhea. It is a serotonin 3 antagonist approved only for females with severe IBS-D with symptoms more than 6 months and who failed other conventional treatment options. It reduces motility, enhances fluid reabsorption, and improves pain. Side effects, mainly constipation. So any drug treating diarrhea will cause constipation for sure. That's why in case of constipation, report and hold immediately. If we have resolution of constipation, we can restart at lower doses. However, if there is no resolution, it should be discontinued. It's also associated with abdominal or GI discomfort and pain, nausea. Infrequent but serious side effects, they include ischemic colitis, which is associated with symptoms such as rectal bleeding, bloody diarrhea, new or worsening abdominal pain. So report and discontinue immediately if a patient develops such symptoms, and alocetrone should not be resumed if any patient develops ischemic colitis. Serious complications of constipation with alocetrone have also resulted in hospitalization and rarely blood transfusion, surgery, and death. It is associated with many drug-drug interactions, and it's contraindicated in patients with constipation, intestinal obstruction, ischemic colitis, impaired intestinal circulation, IBD, severe hepatic impairment, concomitantly with fluvoxamine, which is an antidepressant, and patient education sheet is available for prescriber to discuss with the patient. Cilancitrone is a serotonin 3 antagonist, which have also shown to improve symptoms of abdominal pain and diarrhea in both men and women with IBS-D. However, safety data are still lacking and it's not FDA approved. So these were the treatment options for diarrhea. Now moving to abdominal pain and bloating. So usually patients with abdominal pain and bloating are given antispasmodics on as needed basis, so PRN. For short-term relief of abdominal pain, they will decrease fecal urgency. Usually they are given in IBS-C only if the abdominal pain persists despite treatment of constipation. Also, they may help in treating diarrhea in IBS-D. Examples of antispasmodics which can help, they include mepeverine and pinaverine, which can directly affect intestinal smooth muscle relaxation. We have dicyclomine and hyoscyamine, which have anticholinergic or antimuscarinic properties. So it's very important to counsel our patients about the possible anticholinergic side effects. As we said before, anticholinergic side effects may worsen constipation, which my patient may be suffering from. Peppermint oil and trimibutene have also shown to reduce abdominal pain. In addition to antispasmodics, antidepressants, usually a trial of low-dose tricyclic antidepressant was found to reduce abdominal pain if the patient did not respond to antispasmodics. So TCAs are known antidepressant medications. However, they have analgesic properties independent of their mood improving effects. However, TCAs are associated with constipation as a side effect because of their non-selectivity. They can cause anticholinergic side effects and they can worsen constipation. So make sure that your patient's constipation is not worsened. Main agents among the TCAs which were studied for abdominal pain were amitriptyline, nortriptyline, and imipramine. What is the role of antibiotics, probiotics for IBS treatment? So rifaximin is one of the antibiotics which is not routinely recommended for patients with IBS. However, in moderate to severe IBS without constipation, mainly those with bloating who have failed to respond to other therapies, we may consider rifaximin. So patients have tried a diet which is low in FODMAP, they tried antispasmodics, they tried a trial of TCAs, and they did not respond. We can try rifaximin for a 2-week trial. Probiotics, they have not shown to be effective. So we have uncertain overall benefit with probiotics. Therefore, they are not recommended routinely for treating IBS. So what if my patient had refractory symptoms? What should we do? We should consider the type of the ongoing symptom. What symptom is not resolved? The degree to which the symptom have changed. The compliance of my patient with medication. It's very important to stress on compliance, on adherence to medications, and the presence of alarm symptoms that we will discuss in a few. In case of refractory symptoms, treatment may include psychotherapy, such as behavior therapy, hypnotherapy, relaxation therapy. So they may benefit those with symptoms associated with psychiatric impairment in conjunction with antidepressants. Anxiolytics, can we use anxiolytics for refractory symptoms? We may use them for acute situational anxiety, contributing to symptoms, however, for short-term, only less than 2 weeks. Other therapies which were studied, but their role was uncertain, they include herbs, acupuncture, enzyme supplementation, mast cell stabilizers, but they are not recommended because there is no sufficient evidence for their effectiveness. So this is a summary for the treatment of IBS based on the predominant symptom. So our role, in order to stress on our role as community pharmacists, what should we do? So making a diagnosis, what do we mean? So initially, the pharmacist will need to understand how long the person has experienced the symptoms. So the symptom duration is very important. It's very important for us to understand the family history, lifestyle of our patient, physical exercise, dietary habits, ask about any impact of stressful situation on our patient's symptoms. It's very important to know about bowel habits and look out for symptoms of IBS. For example, if my patient is having unresolved diarrhea, constipation, straining, urgency, incomplete evacuation. So it's very important to ask about the bowel habits. Plus, identify alarming symptoms, red flags. Red flag indicators may help to screen more worrying conditions such as cancer. So where any of these symptoms are present, it is essential that the person is referred to his physician right away. What do you mean by alarm symptoms or red flags? They include weight loss, rectal bleeding, unexplained iron deficiency anemia, fever, frequent nocturnal symptoms, family history of selected organic diseases such as colorectal cancer, IBD, or celiac disease. So make sure to immediately refer your patient to the physician in the presence of such symptoms. Pharmacist-patient relationship, it's very important that the pharmacist foster a positive relationship with the patient in order to aid in successful clinical management. So in order to facilitate a positive relationship, it's important that the pharmacist practice the following principles. So reassure, again, reassurance, reassure your patient that they are not unusual. Identify why your patient is currently presenting. Examine your patient fears. Ascertain the patient expectations and determine their willingness to aid in treatment. Patient education. So again, non-pharmacological, exercise, as we said, lifestyle changes, dietary modifications. So make sure to educate your patient about all the non-pharmacological approaches for treating IBS. Serve as part of the patient support system. Offer your patient recommendation for the adjunctive treatments that we covered now. Advice against therapies that have shown not to benefit patients with IBS. There is no enough evidence to support their use. Identify symptoms which can be self-treated, identify symptoms which can be effectively treated, and symptoms that need referral. Reconcile the medication list to make therapy recommendations for your patient. So finally, as a take-home message, as Dr. Brian said, there is no cure for IBS. Chronic means chronic. There is no cure. There is no single drug that effectively treats all symptoms of IBS. So drugs we have now are useful in certain situations, but they are not to be used indefinitely. Listening is very important. Reassurance is very important. Sometimes simple dietary manipulations, lifestyle changes, relaxation techniques, cognitive behavioral therapy or hypnotherapy may have better outcomes than drug therapy. So patients with IBS may need to work closely with their pharmacists, with their physicians in order to find the treatment and doses that are right for them. And thank you all so much for your attendance.
Thank you, Samar, for another excellent presentation. I think it was super complete. I was not aware of a couple of things you said, so it was very interesting for me too. And I was going through the medications that I dispense to patients and saying, wait, maybe this is an alternative for these patients. So the moment I return to my pharmacy, I will try to have a look at their records in my pharmacy. Thank you so much, Samar.
Thank you, Jaime. Thank you.
Thank you so much. So now it's time for the Q&A part of our webinar. You have the Q&A chat available for you to type your questions for our excellent speakers. And while they keep coming, I will take the privilege of moderating the session to ask a couple of questions that I've been thinking of while you were talking. My first one, this directed to any of you, but it came to my mind listening to Brian. It's about privacy. Pharmacists are very much trusted healthcare professionals. We know how to talk to patients in their language. They come to us trusting our advice, but I think it's evident that we need to improve privacy in our pharmacies. We really cannot talk to patients of some sensitive issues, talking to them on the counter when everybody else is listening in the line. So what's your, in some jurisdictions, it's mandatory that pharmacies have consultation rooms, but sometimes they are not used as much as they should be used because it's also difficult to have it incorporated in our workflow. What's your opinion about this privacy issue in pharmacies?
Yeah, it's a difficult issue, right? Because, you wish you had a private consultation room at every pharmacy. We know space is limited, space is expensive, but you're right. These are sensitive issues for patients. And to explain bowel habits with 13 people behind you listening to all the details, they're not going to give you the details they need. So how do you address that? So assuming you don't have a private consultation room, I guess the question would be, could you move the waiting line to the pharmacy elsewhere to let the counter be a little bit more private? I guess the other option would be, could you do some little telephone consultation, right? And, you know, set up visits so that patients could actually consult with you before they come to the pharmacy. So when they arrive at the pharmacy, you're prepared, and that could be very efficient. I'm not sure about billing issues and how that works, but that might be very clever, and you have assigned slots on the telephone, so it's very private at home. They'll give you more information. Then when you arrive, you're ready to deal with their pharmacy needs.
Great. And here it comes also the telepharmacy thing, technology. Some patients really prefer e-pharmacies that brick and mortar pharmacies are taking advantage of because, again, of these privacy issues. So it's something we really need to consider. I don't know, Patricia and Samar, if you have an opinion on this. I'm sure you have it.
Yeah, if I can add on that, really the telephone does wonders. I couldn't agree more with Brian, and also with younger generations, because we know that IBS is a young women's disease. WhatsApp or any kind of instant message platform that can easily fit it into routines and can really be a better way to engage when everything, as Jaime, you said when we were presenting in the beginning, that everyday life is chaotic at the moment. So it can be a better way to fit into tiny slots of time to take care of ourselves, is to also engage in digital platforms, whatever they may be.
Yeah, very interestingly, while you were talking, there are some platforms that offer a fee per use service, so you only pay what you use, and those are normally you have to take care of that and be sure that it's compliant with privacy regulation, blah blah blah. And there's an issue also with the reimbursement of that very valuable time that pharmacists are investing in patients without maybe selling a product. So, but of course, after COVID, this is a massive wave that it really helps patients have better outcomes, and it's more convenient, and it really puts the patient in the center. So instead of coming to our pharmacies, wait a line, wait that the pharmacy is open, talk to a pharmacist, and while everybody's listening, maybe this for sure, this technological platforms and or telephone, as Brian said, very well said, is a solution. So Samar, if you have.
Yes, I totally agree. I wanted to add that I live in a village, and usually local pharmacies or the pharmacists are known by everybody, by the neighbors, by their relatives. So usually they text them using WhatsApp, by telephone calls. So it's very, as you said, especially during the COVID pandemic. So in order to keep social distancing, to avoid contracting the virus, so they depended on the texting and calls. So it would be an important way.
Yeah, as long as it's compliant with the privacy regulation, which of course changes from country to country. Excellent. Thank you so much. So I have another question. Patricia was talking during her presentation about red flag symptoms. You talk about referring to the other healthcare professional, not only the specialist or the GP. And it was my question was partially very well answered by Samar during her presentation. So she mentioned in a very concrete, specific way what are the red flag symptoms for IBS diagnosed patients. But I would like to ask you, what are the red flag symptoms to refer to another healthcare professional prior to the IBS diagnosis, or even more widely to any GI gastrointestinal disease or symptom? What are your thoughts on this?
I think starting off, maybe making a bridge to what Brian talked to us about when talking to IBS and the Rome criteria. It's really simple questions that you can integrate into everyday life as a community pharmacists, that sometimes people even start to answer them even when you don't ask them directly, because sometimes when they come for a laxative very often, or on the other way, if they need some kind of prescription or some kind of OTC to make their bowels function normally, you can really start the conversation. So it's been often that you've been coming here with this kind of complaints and symptoms. How long have they been going on? And the Rome criteria has been so easy to fit into, when I was a community pharmacist, to fit into my conversations with my patients, because I had those 3 hotlines that I really needed to cover, but the conversation just flows and you get the most of it without being very fixated in what is and what is not. And at the same time, and particularly in Portugal, we have a high count of GI cancers. And it's also a very good time to do that kind of screening also, and to see when and if it's needed to referral, because we are talking about a disease that has a high impact on quality of life. But personally, I'm also very concerned always when people have recurrent symptoms of GI, that it might be something else that is being covered or mistaken by just another day. So I think it's so easy to fit into our everyday practice, to be aware. It's the main issue for me, is to be aware that these are questions that should be part of any kind of counseling, even for women who have heavy periods or have period pain and usually have abdominal discomfort. We should be asking everybody these kind of questions and starting these conversations.
Yeah, absolutely. We are privileged with the fact that we face patients more often than any other healthcare professional, and we cannot be happy only by handing the product that the patients need, or sometimes they even do not need. It's our role as pharmacists to be sure that this product is adequate for that patient. Thank you so much. So Brian and Samar, any thoughts on this?
So I'll just jump in quickly. So Patricia nicely covered all of them, and they can be very quickly done as she highlighted. The key questions I ask about IBS: family history of inflammatory bowel disease, family history of colorectal cancer, family history of celiac disease, unintentional weight loss of more than 10%, a history of anemia or hematochezia. And the other things I would highlight too for other GI disorders: dysphagia. So if people are having problems swallowing, they probably need referral, and persistent intractable nausea and vomiting, of course, vomiting blood. But those are the ones that I think you can quickly do. This took us, 17, 18 seconds. You covered a huge amount of ground, and as already highlighted by Patricia and Samar, you can really benefit your patients.
Jaime,
I muted, Jaime.
Yeah.
Oh, sorry. It's been a while since it didn't happen to me. I'm sorry. So Samar, your turn if you want to add anything.
So I totally agree. I have nothing to add. It's very important to address such red flags. So Patricia and Dr. Brain have covered them all.
Thank you. Thank you so much. My last question would be, while you were presenting, Samar, you insisted very rightly about the supplements or the other products that patients might be taking that need to be supported with evidence, of course. Yes. I have a patient that sometimes comes and buy a lactase supplement, which is not even a medicine in Spain. Do you know what evidence is? I mean, the patient prefers that her symptoms improve, but what's the real evidence? Are you aware of this?
So your patient doesn't have lactose intolerance, you said?
No, IBS. She's not diagnosed with that, IBS. So
based on studies, there's not enough evidence. When I say there's not enough evidence, some studies have shown some benefit, whereas other studies may have shown side effects or exacerbation of the symptoms. That's why we don't have valid evidence in order to support their use. So In clinical practice, we may see some patients who can benefit from certain medications which are not approved off-label use for certain diseases. So herbs sometimes may help. However, we cannot, as pharmacists, provide prescribed patients herbs. Enzyme supplements sometimes also can help. Some patients may go for acupuncture, and it was found also to help, but we cannot support because there is no enough clinical studies, randomized trials supporting their use. This is the point. But some patients may have some benefit on that.
What she says is that when she is invited to a wedding, or sometimes that she cannot control her diet, she just takes
supplements.
She takes one and just.
Maybe Dr. Brian may help us in this.
Yeah, I'll quickly highlight a few things. So I like exactly what Dr. Yunus just said. So one is there's really very little evidence. Number two, as pharmacists, you have a great opportunity to educate patients. Remember, many of these supplements have never been tested. Some are very expensive and some are actually dangerous. So you have a great opportunity to educate patients that just because they're out there doesn't mean they necessarily work or they're safe. Another great teaching point is also don't forget that sometimes things overlap. So people can have IBS, and as I already mentioned, 35% may have lactose intolerance as well. And so sometimes you need to be treating both things. But I think it's a great opportunity for everybody in the audience to look at the data. There's so little data for probiotics and supplements, and sometimes they're quite expensive and they can be risky in some patients.
Oh, probiotics, that's another huge trend in the market. We need to have another webinar on that. So Patricia?
Right.
What's in this?
Couldn't agree more. Probiotics are really getting into everyday life. But just building up on what Samara and Brian already shared, I couldn't agree more that we really need to be patient specific to analyze these kind of questions. What other medicines or drugs or supplements or herbs or teas or etc. are they taking? Are we really aware of all that information and what is building up and taking away? Because sometimes my worry when I have patients taking probiotics is what is working against their own microbiome, what's correcting or taking some damage in their microbiome. So I'm always very cautious when people approach pharmacists about probiotics, because I don't think we have in general enough knowledge without doing some samplings, without analyzing each patient to better fit what they need as for probiotics in general. So probiotics is really an excellent subject for a next webinar.
Yeah, thank you, Patricia. I cannot agree more. More research, more evidence. So thank you so much. This was the last question. So I will go now into the wrap-up and conclusions. If I can have the next slide, please. We are excited to invite you to the 18th FIP World Pharmacy Congress of Pharmacy and Pharmaceutical Sciences in Seville, Spain. The Congress will take place from the 18th to the 22nd of September under the theme Pharmacy United in the Recovering of Healthcare. Registration and abstract submissions are already open. For more information, check our website, seville2022.fip.org. So I will finish here. You can check this event and the future FIP digital events at events.fip.org. It was a privilege having you here. A super big thank you to our 3 speakers and of course to you on the other side of the screen who are very busy practitioners and took 1.5 hours of your very valuable time to improve your education on this very important and interesting topic. Thank you for attending. Bye-bye.